evening, everyone. My name is Meredith Tui, and I'm the Conferences and Events Manager at the American Nutrition Association, the ANA. The ANA would like to thank Bragg Health Foundation for their support of our 2018 Global Webinar Series. Learn more about their mission to inspire and educate people to adopt a healthy lifestyle through optimal nutrition, exercise, positive attitudes, and spiritual wellness at bragghealth.org. The American Nutrition Association is very pleased to be hosting Dr. Robert Bonakdar tonight to explore how food can be used as a pain management intervention. Let me take just a moment to tell our audience about the ANA. We are a nonprofit organization which for over 40 years has been on a mission to promote optimal health through nutrition and wellness education. We educate the public and professionals in many ways, including hosting world-class nutrition programs such as this one tonight. We encourage all of you listening this evening to visit our website at theana.org for an abundance of nutrition information, resources, and upcoming webinars. Join the ANA as a member and help us continue to bring these nutrition luminaries to you. And now we are honored to introduce Dr. Robert Bonakdar. Dr. Bonakdar is the Director of Pain Management at the Scripps Center for Integrative Medicine. He also serves as Assistant Clinical Professor at the University of California, San Diego School of Medicine and is a past president of the American Academy of Pain Management, now the Academy of Integrative Pain Management, which is the largest U.S. integrative pain management organization. Board certified by the American Board of Family Practice, Dr. Bonakdar is a member of numerous professional organizations, including the American Academy of Family Physicians, the California Academy of Family Physicians, the American Holistic Medical Association, and the American Academy of Medical Acupuncture. He has conducted award-winning research and presented at numerous conferences in the area of herbal and natural medicines. Welcome, Dr. Bonakdar.
Thank you. Great to be here. So today I was asked to talk about nutritional pain management. I wanted to talk specifically about the rationale and implementation of a program that could help bring nutrition into the discussion of pain management. My faculty disclosures are listed here. And as background, the material I'm about to present is actually taken from a larger CME program that's through the the Academy of Integrative Pain Management, formerly the American Academy of Pain Management, where we did a 6-hour course. And I'll tell you a little more about that. We will actually be repeating the full course with some updates in November in Boston, and there is some information about the conference as well as a discount code for the ANA members and attendees of this webinar if you'd like to have more in-depth information on that course. So with that as the background, I want to go through some of our objectives for how to look at nutritional pain management. I think it's important to look at how we define it. I'm also going to go into the background of nutritional pain management, both why it's not being done, as well as some background on what the U.S. pain care environment is and why nutrition is so important. What are the implications of when nutritional pain management is not done, and how do we implement it when we decide that it is an important thing to do? What are the starting steps? I'm going to give you briefly the results of a trial based on our previous 6-hour course in training clinicians to bring in nutrition into their practice, and finally some conclusions and next steps. So as far as definition in this area, we know that diet and nutrition, they're very big topics. Diet can mean many things, not only what we eat, but how much we eat, how fast we eat it, where we eat it, the environment where we consume it, as well as components of what we're actually eating, nutrients, the patterns we might be following, the food, the supplements, as well as what things may be causing issues, maybe causing inflammation, triggers, and what we choose to eliminate, and a whole host of very specific dietary patterns or ways that folks are incorporating diet, both to reduce their pain as well as multiple other symptoms and conditions. So there's a lot of ways to look at it. Just to simplify it for our discussion, we know if we look at just diet as a simple definition, looking at the kind and amount of foods that are prescribed for a person for a specific reason. So, for example, that could be hypertension, like the DASH diet, but in our case, we're going to talk about what that might look like for pain. A dietary supplement, again, is a product taken orally that contains one or more ingredients, such as vitamins, are intended to supplement one's diet. I prefer, and we chose when we did the course, to use the word nutrition, just because when you look at the definition of that, it tends to summarize all the processes by which we take in and utilize food substances, whether they are food as part of a meal, dietary supplements, or other nutrients that are utilized to supplement that. So we're going to talk about that as a nutritional pain management. As a whole definition is to look at how do we evaluate and optimize nutritional status to ameliorate pain and related sequelae such as depression, fatigue, obesity, which often coexist with pain. So finishing definition, going into the background, what are the key areas that we're going to be looking at here? And those are going to be under-recognized and underutilized in pain versus other conditions. And we're going to try to look at the reasons behind that. We're going to look at why pain is sometimes seen as more of a question mark as far as its efficacy than we really are looking at it as something that we feel very confident about. There's definitely a source of undereducation, undertraining that we'll talk about, and also on a slightly separate topic, the background of pain care in the U.S. So when we talk about how other organizations look at this, we see many large organizations such as the American Dietetic Association, the American Heart Association, subcomponents of the field of psychiatry, looking at diet being very important for certain aspects of the population that they care for, whether it's diabetes, heart disease, mental health. When we transition and look at some of the literature in the area of pain, what we really see is that it's more of a question mark. So food and pain, should we really be interested in what our patients eat? Does it matter what our patients eat? Which is a follow-up to the initial study. And other articles also are talking about diet in the context of pain management or conditions that have pain as part of the condition, but really looking at it as more of a question mark and something we really feel strongly about. So that's an issue that we'll come back to. In general, within clinical care, especially conventional care, a lot of this comes down to the fact that nutrition takes time, it takes education, it's nuanced, it's rapidly changing, and clinicians, for the most part, prescribing clinicians feel much more comfortable using drugs than foods because of those intricacies. And so food as medicine, in this case as pain medicine, tends to be largely neglected, as this editorial mentions. What compounds this is, or contributes to it, is the fact that many clinicians do not have significant training. The minimum number of hours, which was set for quite a while now, 25 hours, is not met by the majority of medical schools in the United States. So it's not really surprising that when clinicians have the opportunity to talk about food as an intervention, they don't really feel confident to go into it to any significant depth, and in many cases that discussion never happens. Going to the background of chronic pain, we realize that it is affecting at least 100 million Americans in various ways, and is looking at chronic pain, and that the cost of chronic pain is actually far exceeding the cost for many other chronic conditions, whether it's cardiovascular disease, cancer, diabetes, etc. And the key point here, which also is one of the issues of why it may not get as much attention, is it's an overriding phenomenon. So it may be linked to diabetes such as neuropathy, it may be related to cancer-related pain, or cardiovascular pain such as angina. So even though it's its own entity in this case, we're looking at the cost of it, it really is connected to many other conditions, and sometimes it's seen as a subsidiary of those conditions as opposed to its own entity. When we look at management of pain in the United States, we know that we have weaknesses. We have areas that we could improve on. I'm going to give you 3 examples of that, the first one being in chronic neuropathic pain. We know that although shorter-term clinical trials have shown benefit for certain prescription medications, the longer those patients are tempted on these pharmacotherapy options, at 1 year, only about a quarter of them are really helped, showing the complexity of a condition such as neuropathy. So showing that there's definitely space for other interventions. Similar is true for fibromyalgia, another very complex condition which we'll come back to with some clinical evidence on the use of diet, is that in many cases patients do not do very well with long-term use of medications. They may have short-term benefit. Over long-term, many folks do not either tolerate it or find significant benefit. So again, a population in need. A third example is migraine. This is an area where there's definitely nutritional components that we'll talk about. If we look at the middle to the right of the screen, we can see that a good majority of the population is looking for additional options, and they're not fully satisfied with what they're getting currently, which for the most part, as we talked about, does not include significant nutritional interventions. So putting this all together, the Institute of Medicine in their 2011 summary basically said we need transformation in pain management, that treatments more and more should tailor pain care and really utilize self-management approaches in which we can definitely look at nutrition as a key example of that is not currently being promoted to the degree it could be. So in addition to background, what are the implications now if we continue on this course of not using nutrition to combat pain? What does it look like if we continue with our current dietary patterns, and what are the consequences of that? So first, I like to look at nutrition as a potential pain medicine or pain management modality. And the ways it can do that is we know it can modulate inflammation. We know it can modulate certain receptors that are key in pain management, including NMDA receptors, modulate neurotransmitters, hormones and prehormones, organ function, and specific symptoms such as the endocannabinoid aspects of nervous system, immune system, which are key in pain management and inflammation. And it has also been shown when incorporated appropriately that it can modulate the requirement for other medications and treatments. We also know that proper nutrition not only helps pain, but while helping pain or independently can also improve areas of sleep, mood, and stress. So as we begin this discussion, if we're trying to arrive at that potential, we really need to figure out why we're not going towards that potential. And one of the key reasons is the current state of the plate, so to speak, of the American diet is quite poor. Highly processed foods make up the majority of what Americans take in, and even the areas that are plant food that should have bountiful phytonutrients, as we'll talk about later, are also processed. So they're depleted of some of the key nutrients that may be part of the pain medicine that we're hoping for. And this has been looked at both in animal and human models. This is an animal model which looked at a total Western diet, another way of looking at the standard American diet, another term for it, where specific components were given to animal models and found that it altered nociception, so heightened levels of pain sensitivity, increased inflammation, and pain levels. So we all kind of can guess what these components might be, and this is just an example of the kind of what I call the highs and lows of the standard American diet. Some areas that are quite low and other areas that are quite high, especially in the processed, caloric, and glycemic aspects of these foods. There's other components that we'll talk about as well, which also I believe are, you could argue, are part of the standard American diet. So when we have the standard American diet, what we see is it can promote low-grade inflammation and hyperalgesia, as we've talked about. It can also cross-promote a number of other aspects of what our pain patients often come in with, including obesity, deficiency, increased oxidative stress, dysfunction in their microbiome, and based on their epigenetic background, more propensity for pain. Putting all this together, many times when we see folks in pain, it also has downstream effects, including the way they choose the foods that they're going to eat, which can then continue the cycle of the standard American diet, promoting more inflammation and pain. It can also change their mood. It can change their function, activity, etc., as we'll talk about. So when we talk about inflammation, it's not just one thing. As we realize, it's many times both triggered by as well as contributing to dysfunction in a number of areas. So we're going to give a few examples of these. We can't go in depth in all of them, but some key examples as we look at how we're proceeding with that circular vicious cycle of inflammation. We know that as inflammation increases, one key example is C-reactive protein, which many of us are familiar with, as well as other cross-promoters such as obesity. There tends to be increased pain. In this case, just having elevated CRPs while controlling for overt reasons such as autoimmune disease. These are typically otherwise healthy subjects who tend to have this low-grade systemic inflammation, had higher levels of low back pain, in this case had twice the levels of low back pain. Other studies have corroborated this. This is in an older population that elevated CRP also was associated with higher pain intensity as well as pain interference, so interfering with things like mood, activity, sleep, etc. And so when we think about how this happens, in addition to just intake of foods that may be inflammatory and then cause a downstream inflammatory effect, we also need to look at the fact that these depleted foods also cause a depletion of our microbiome. So, and this can happen very quickly, that as we get more processed foods, low in fiber, low in phytonutrients, we're also not allowing the microbiome to fully flourish to arena where it can actually cause a reduction in inflammation and pain. And again, when this happens, there's a number of pain models. Visceral pain models tend to be the one that are most significantly studied. In this case, chronic prostatitis, chronic pelvic pain have this lowering of the microbiome diversity and or dysbiosis, such as in IBS, where certain populations which tend to be more inflammatory are heightened, and loss of diversity in some of the protective aspects of the flora. A lot more work needs to be done here, but those are some general trends that are described. As far as immune contributions to inflammation, we know when certain foods or certain dietary patterns can increase histamine. Those are some of the key reasons why folks go on to have visceral pain, as we've already talked about, as well as things like headache. Another emerging area of pain promotion is through cell-mediated mechanisms of pain. And we know that when we look at a number of areas of pain, there is a mast cell component, which is somewhat linked to histamine, but also other conditions that we see here, which may be related to mast cell overexpression in an area that may be promoted by an inflammatory diet. There is also emerging research on epigenetics, noting that in some twin studies, that when there is one population that is able to have epigenetic trends met with proper nutrition, there's less propensity to pain. The best model of this is actually post-surgical pain, whereas in other environments where that nutritional intervention is unmet, there tends to be a higher level of pain. Deficiency needs to also be considered in this area. We know that the majority of Americans do not get enough magnesium in their diet. About 20% don't even get half of the recommendations. And this, at least in several studies, has been shown to have a direct impact on C-reactive protein because of the importance of magnesium in several areas. So this could be part of the reason why some conditions such as migraine have a much higher propensity to not only inflammation, but to going on to actual pain states. In this recent study, it was found that magnesium deficiency increased the odds of migraine by over 35-fold. So it's an area that we really need to keep in mind when we're seeing pain patients, that something as simple as magnesium could have a very profound effect on the progression of their disease. Another example is coenzyme Q10. I picked this specifically because this deficiency can develop very early. So it's not decades and decades of a certain condition. In this scenario, these pediatric patients who had migraine began developing coenzyme Q10 deficiency by their early teens. So it's something that, again, if we're seeing them later in life, we need to really figure out how long has this been going on. And we'll come back to the second half of this study later. Those are just a few examples. Many other deficiencies that have also been linked to pain to keep in mind. When these trends do continue, for the most part, we see a very strong correlation with obesity being promoted with pain. Even though it didn't develop initially, pain can sometimes cause some of the inflammation to go on to cause insulin resistance, etc., that can make obesity much more likely to be seen as a comorbidity. And in fact, in this review of over 1 million subjects, they found that there was a very significant association between weight and pain. And in fact, the higher the level of obesity and the age, this trend became stronger and stronger, especially in women. This is an article that's free access that goes a little deeper into this trend that I wrote a few years ago, trying to explain the connections between pain and obesity, which in many cases are through their cross-promotion of inflammation. Another key aspect of the obesity trend is what it's doing to insulin resistance and glycemic control. This is a 20-year study which looked at the fact that osteoarthritis, in many cases, that progresses to joint replacement, can be impacted with proper glycemic control. In this study, that is exactly what happened. When glucose metabolism was better managed, there was less propensity to go into joint replacement. So this is an aspect of not only only pain, but kind of a more significant intervention and sequelae that hopefully we can prevent using nutrition. As we talked about inflammation, obesity, insulin resistance, one of the other key areas that's developing and emerging is adipokines, are cytokines that are being secreted by our adipocytes that may not stay local but actually go to areas where we might have pain in non-weight-bearing joints. So taking the example of someone who's obese, has metabolic syndrome, and is not just having pain in their knees and low back and hips, but in this case in their shoulders and their carpal tunnel. And there's some evidence now showing that things like leptin may go to have issues that cause pain, and other adipokines may also increase propensity of pain in areas like headache, which has a strong association with increasing odds with obesity. So as we continue this discussion, we know that in many cases these are being done simultaneously. So we're not only have a population that's eating a deficient diet, but they may have a diet that's high glycemic load, otherwise depleted, and creating the scenario where that inflammation is swirling around. So as we do this, we need to talk about how things like magnesium, as an example, can come in and not only reduce inflammation, but modulate receptors and then go on to hopefully reduce the propensity to promote metabolic syndrome. While we're talking about diet and pain and other sequelae like metabolic syndrome, it's very important to keep in mind that we're talking about a larger discussion. Although we're talking specifically about pain, pain is often associated with cardiovascular disease. And I wanted to share some recent studies that basically pinned diet. For one of the first times in history, we really look at poor lifestyle as a promoter of chronic disease. But in really putting the magnifying glass on this and looking at multiple causes and risk factors, a recent study just a few months ago, and a poor diet was at the top of that list. Unfortunately, many of the other things that go along with poor diet and unhealthy lifestyle typically contribute to creating that vicious cycle, so that patient that has one may have multiple aspects of these risk factors. Going even a little bit deeper, this study also looked at the dietary trends and tried to look at what areas may be most contributory to cardiovascular disease. And I put this up to show you that many of the things that we'll be talking about, such as abnormalities in the amount of omega-3s, low fruits and vegetables, glycemic intake, are also contributors to chronic pain. So with that as sort of the negative implications, what can we say about implementing a program to help initiate pain and symptom management? So going back to our model, in many ways, although it's simply said but maybe more difficult to incorporate, we need to reverse this trend and begin to turn counterclockwise so that the standard American diet can be switched to an anti-inflammatory diet. so that it can begin to promote an anti-inflammatory potential. What does that look like? So we, for our 6-hour course, kind of came up with some of the key components. We're going to be going through some of the key aspects of this, but they start with minding our P's and Q's and R's, starting with preparation, our pace, and then going on through some of the other areas where some may be familiar with, as far as the 5 R's, as far as repairing, reducing, replenishing, and rebalancing, as well as reducing certain trigger foods. On the far right, we're going to come back to some other components like physical activity, quiet and rest, which are important as well in getting the full benefit of our diet. A question with such a complex approach, especially when there's not a lot of training and maybe not a lot of knowledge on the patient side and not a lot of resources on the clinician side, is where to start. Although there are many great anti-inflammatory foods, the key point I make is even if you're eating those, if you're doing it in a setting where you're rushed and you're not really mindful of what you're doing, you're still maybe over-consuming those and really not looking at the bigger picture. So I think mindful eating is something that it's important to share with our patients as a starting point before we delve in too deeply into the dietary specifics. We do know that if we do not eat mindfully, there's a number of studies that show fast eating can not only increase caloric intake, but it can also increase inflammatory state. So again, a healthy diet eaten in an unhealthy manner can have consequences which are the opposite of what we're trying to create. So that's a good place to start. Also, when we tend to eat more mindfully, we tend to have a slightly lower caloric consumption. We know most Americans typically eat more than they should. So in this scenario, what we're really finding is that we are able to have folks, through this mindful practice, get less calories in than typical less mindfully consumed meal. And some studies show anywhere from 10 to 15% reduction in actual food, or anywhere from 50 to 90 calories, which over the day, that's per meal, can add up. And that simple reduction in caloric intake in many cases can also impact inflammation. Again, not looking necessarily at what we're eating, but how we're eating. Then assessing how the current diet is made up is, I think, important as well. I think in the scenario with questionnaires, there's many, I put some in the appendix, but just from a starting standpoint, just looking at phytonutrient intake, how often they're eating out versus eating in, how often are they cooking versus eating packaged foods, what is the makeup of the drinks that are usually had, what are their intake of potential additives and preservatives. Those are all areas that we can begin to get a sense of, is diet pain promoting or pain relieving in this population. When we take another deeper look at where this is all beginning, I think it's important to also look at the gut as a starting point, because that's typically where a lot of this inflammation starts. When we look at how inflammatory diet can deplete the microbiome, go on to cause inflammation, permeability, the LPS, the lipopolysaccharides can go on to signal inflammation, as we'll talk about later. So this is really where a lot of the inflammatory potential begins before we go on to systemic inflammation and insulin resistance, metabolic syndrome, cardiovascular disease, etc. So that's why it's important to, in many cases, reduce what's hitting the gut. And if we can give our patients some simple tools, guidance of, here's how to avoid some of these potential triggering foods. I've linked a few websites here. The second one has a nice step-by-step guide of how to reduce, and then begin kind of restocking with anti-inflammatory foods and potential in the pantry, fridge, and begin to really incorporate that in our daily routine. I think one of the key areas here is that although we think of anti-inflammatory foods as something maybe complex, it shouldn't be that complex. And there are folks who are trying to simplify it. So there are researchers who have for some time been trying to come up with anti-inflammatory scores for certain foods and using those scores to predict where someone might be more prone to go on to inflammation. There are also, this is an example of a questionnaire that just looked at 20 foods. What they basically looked at are how likely are the subjects to eat anti-inflammatory foods such as more fruits and vegetables versus things that we know pretty definitively are pro-inflammatory, such as highly processed foods, chips, sweets, things like that. And just looking at 20 core foods, they could also predict the folks who are going on to have higher levels of inflammation, even while controlling for other potential contributing factors. So it's very fascinating that even just looking at some core foods, we can begin to understand what's inflammatory and what's anti-inflammatory. The reasoning behind that is if you take 3 examples, and this is out of a research study of a fast food diet, we could think about what that might be, and the drive-through where somebody might get that, a Mediterranean type diet, and one might make breakfast, lunch, and dinner, or a more simple macrobiotic diet, and then putting that through analysis, we can see, again, negative scores are more anti-inflammatory. Both the macrobiotic and Mediterranean diet have significantly lower negative anti-inflammatory scores, and the fast food diet, simply because you see that in many cases it's depleted of a number of nutrients across the board compared to some of the other areas, including our polyphenols. It is very easy to see why the pro-inflammatory diet actually goes on to cause inflammation. This is something you might be seeing down the road. The Dietary Inflammatory Index is a label that is being proposed to help consumers, similar to how they might more simply look at added sugar and other things to really understand how this food might help or contribute to inflammation. Another easy place to start is just increasing polyphenols, finding food that they can tolerate and enjoy, and there's huge lists of those. Good resources, Environmental Working Group, and they also have lists of which ones can be accessed in different parts of the year, and they also look at pesticides and other important factors when we look at polyphenols, which are important to share with our patients. But that's an easy to go-to site. We also have a number of other dietary components which begin to help us understand how things such as in garlic and other members of the family can reduce certain aspects of promotion of, in this case, joint pain. So the matrix degrading proteases are typically an area where we can have a promotion of it. In this case, with certain dietary input, we can repress that mechanism. We also know that polyphenols, again, Camphorol, this is the most abundant polyphenol in a number of the foods that many of our patients are eating. If they're eating these in a significant degree, such as in teas, fruits, vegetables, and beans, can actually have a significant anti-inflammatory and anti-nociceptive benefit. So that's a pretty easy way to make the transition there. As far as clinical trials, they are beginning to happen. This is a great example of a pilot study looking at fibromyalgia patients and increasing their polyphenol intake being associated with a lower number of tender points and better quality of life when this transition happens. For a number of reasons, we can kind of understand that. We also know that if we can help our patients through fruits and vegetables, as well as other avenues to increase their fiber, that has been shown in a number of studies, including 2 prospective cohorts, to reduce the risk of worsening knee pain. So in many cases, we're seeing patients with pain, and we're looking at ways to reduce the progression of it and improve their overall functionality as they're aging. And now we can definitively say that fiber, increasing that, is a way to do that. This is another study, a larger study, looking at knee pain as well, showing that fruits and vegetables, again, may help improve the level of knee pain. I put this model of endometriosis because I find it a very interesting model where we know versus people who have minimal intake. For example, this is looking at the control is less than 1 serving a week versus those who have citrus foods at least once a day, 22% reduction of endometriosis. On the flip side, versus those who seldom eat red meat or processed meat, those who have 2 or more servings have a more than 50% increased risk of endometriosis. So you can begin to see the choices that our patients are making and how we can hopefully guide them can make an impact on their pain condition, with endometriosis just being a more classic model. One of the key things that often is not discussed that I think is very important is many of our patients have issues with polypharmacy. They're on a number of medications for a number of conditions, both pain and otherwise. And there's some emerging research that is beginning to show that healthier diets with healthier components of fruits and vegetables, polyunsaturated fatty acids, and specific nutrients may actually reduce the need for certain medications, in this case looking at glucocorticoids in lupus. Lowering the overall glycemic load, glycemic impact of the diet appears to be important. There's a number of studies that show that it can reduce C-reactive protein while improving the anti-inflammatory adipocyte known as adiponectin. So that's an important thing to try to promote, and it seems to be helpful while simply by lowering the glycemic hit that each meal has for our patients. Talking a little bit about deficiency, we know that certain nutrients such as magnesium are very important. We already talked about them being deficient in the vast majority of the patients we might be seeing. This is showing that repleting that in various ways. This is an example of magnesium glycinate in a pediatric pain model, as well as simple magnesium supplementation, looking at those who have an inflammatory state, does reduce inflammatory markers. So we're both helping. We know we can help the serum levels of inflammation as well as the overall overt expression of pain. And it doesn't take much. This is an example of just 100 milligrams extra per day of dietary magnesium can have a significant impact on a number of inflammatory markers, and just a few examples of where folks might be guided to get that. If we go one step further, we know that magnesium not only increases CRP, it may do that directly in some respects, but it also, through its depletion, we know can alter the gut microbiome, and that can lead to things like depression in addition to pain. So this is an interesting study that found that using just 500 milligrams of magnesium oxide was quite helpful in helping, and this is an animal model, in reducing depressive behavior. So magnesium is important for many reasons, and like many of these nutrients, is not a direct effect in some cases with pain, but because of its inflammatory associations, its change in the microbiome, its change on the epigenetic level can contribute to pain and other sequelae. This is a return to a study we had earlier with the adolescents who had low CoQ10. Those who were repleted at 1 to 3 milligrams per kilogram had significant benefit on their headache disability, both frequency and severity. Vitamin D, we've heard a lot about that. We do know that cellularly it can increase pain hypersensitivity, especially when it's deficient in certain chronic pain states. There is a gradient of the more deficient we are, the more likely that patients are going to have pain hypersensitivity. Unfortunately, it's a little bit harder to see the benefit of that with repletion, but there's really no benefit to being insufficient or deficient. So at a starting point, we need to really continue the discussion of getting our pain patients, especially those on analgesics, to be repleted and continue to test and treat. In this scenario, 4,000 units a day of vitamin D had significant benefit versus placebo, not only helping with pain scores, but there's a mechanistic understanding that there was a reduction in some of the inflammatory markers. I would say similar things happen with omega-3s. We don't have enough time to delve into this too deeply, but I wanted to share this one study where when omega-3s were heightened and omega-6 through dietary measures were lowered. So sort of the fats that many times are happening in processed foods or packaged foods are lowered, and more fresh foods with high omega-3s were incorporated. Headache scores and total medications for headaches reduced by 37 to 43% when we had both high omega-3s and lowered omega-6s. So it can have a significant impact on a number of pain conditions. while we're finishing the supplement discussion, I just wanted to mention that every January we have a conference, which is now going in its 16th year, which focuses a little more on the evidence behind some of these supplements and how they can be a strong adjunct to a good dietary approach. And we have a lot of discussion because many of our patients are also trying to figure out the best approaches on both ends. And there's a discount code as well. When we talk about fixing the gut microbiome, there's many approaches. We talked about increasing fiber, which and the use of fruits and vegetables, which is a significant starting point. That's always the best place to start. But I'm going to talk a little bit about other approaches, and those most typically are probiotics. We know that as patients are beginning to have questions about probiotics, we can begin to say that in addition to having other benefits in increasing diversity and maybe changing GI symptoms, we can begin to say that they have an anti-inflammatory effect. And again, we're talking about LPS, lipopolysaccharide activation of inflammation. This is the area that, again, begins in the gut, and we can begin to see some benefit with certain strains. Also, dietary shifting, which may change the microbiome milieu, not only helps GI symptoms, but interestingly helps conditions such as fibromyalgia, which are very commonly coexisting with patients with IBS. So keep that in mind when you have your dual diagnosis patient, that some elimination diets such as FODMAP are not only going to help their GI system, but also their pain. This is a very interesting article. Again, all this is very preliminary, but looking at the fact that probiotics can have a significant impact in some difficult to treat populations, such as those with rheumatoid arthritis. When we are looking at other conditions, we are beginning to see that probiotics are likely going to come to a forefront of not just chronic pain, but some acute pain. So you might begin to see them in a perioperative setting. I would guess in the near future. This is a preliminary study that showed that it can be beneficial in reducing aspects of acute pain. So keep that in mind as you go forward in looking at how to change the gut to change pain. Probiotics are probably going to be part of the scenario. So as we look at the multiple aspects, and hopefully we touched on a number of the areas that were interesting to you, I think it's also important to look at the other P's and Q's to help the diet be most impactful. And that is, what's the pattern of the diet? So in many cases, we're not just talking about a certain isolated nutrient, but certain dietary patterns. And again, many of the patterns that we're getting a lot of evidence on and interest in are things like the Mediterranean diet. We know that certain components of that can sort of add up to create a perfect anti-inflammatory menu for patients based on the micro components and the phenolic compounds and the healthy fats. This is an excellent example of why we can understand how it might impact something like arthritis. We already have background evidence that it can significantly help serum levels and inflammatory markers, and there's more resources on the Mediterranean diet in the appendix. This is a nice example of a study where they taught a population that had really no idea about the Mediterranean diet, no training in making it, and found that both during the course of the training as well as for several months after that, continued to have significant benefit in reducing their pain and symptoms associated with rheumatoid arthritis. So again, great example of how diet really can be good pain medicine. Okinawan diet I put as an example because although the Mediterranean diet is great, there's many other traditional dietary patterns which are different in subcomponents, but again have some of the important aspects of healthy fats, healthy intake of fruits and vegetables, etc., which can also be very anti-inflammatory and helpful for pain relief. Other aspects that are often overlooked are in the lower right are physical activity as well as quiet unrest. Knowing that we tend to sit as Americans more than we should, it is important to keep in mind that if we are eating a healthy diet, but we're eating it mindlessly, we're going to tend to eat more than we probably need to eat. We also know that in many cases when we combine that excess caloric intake with low physical activity, we are creating a propensity for obesity, metabolic syndrome, et cetera. So it's very important to discuss being more physically active with our population and the synergy that happens. This is the IDEA trial, which looked at obese osteoarthritis patients and found, again, that diet and exercise here on the lower right can take folks with higher levels of pain and take them to more moderate levels of pain, and that diet and exercise work well together. So it's usually best in combination. I did want to talk about a trial where we tried to answer the question, can you train clinicians to care more about nutrition as an intervention for pain? This was a 6-hour course. Our objectives were to assess their comfort level with having discussion around nutrition, then giving the intervention, and then having a post-survey, as well as looking at specific aspects of the components to make sure that they gain knowledge during the course. So I'll just jump ahead to what we found. As you could imagine, the confidence of these providers was very low. So the confidence in the pre-workshop was very low in being able to give good evidence for details of how a dietary approach might help with pain management. After an intervention, they strongly were able to incorporate, they strongly agree that they had confidence in providing details of a dietary approach for pain, such as how to incorporate the Mediterranean diet, what nutrients, supplements might be most important, i.e. magnesium, vitamin D, etc. Similarly, this population increased significantly their confidence in responding to questions, such as a patient maybe asking, what are some sources of magnesium? And this came both based on a discussion as well as a number of handouts that we provided that clinicians could use to more easily answer questions about nutritional pain management. This is one example. This is taken from the VA. Dr. Nancy Cotter, my co-presenter for the 6-hour CME workshop. This is a handout they have at the VA in New Jersey where they gave patients very simple guidance of what is an anti-inflammatory approach and how can you minimize pro-inflammatory foods, which those combined can begin to have some pain relief in this population. So finally, in conclusion, I wanted to put together a few ideas of how to make nutritional pain management happen. The key step is to realize we're not doing a very good job right now as a healthcare force. There's obviously many folks, including those on the line here, who are doing an amazing job, but I think we need to realize that currently in the U.S. nutritional intake is not optimal. We've known that for a long time, and as the recent JAMA article showed, are the most impactful area of going on to cardiovascular disease. And pain is often contributing to or connected to those significant causes of morbidity and mortality. And so we need to realize that as a starting point. Also, we need to better recognize that although other conditions have done a good job of connecting nutrition to improvement of those conditions, whether it's the ADA, the American Heart Association, the Psychiatry Association, nutrition in pain can also happen. But it will take advocacy. It will take us within our own organizations to put out statements and work and publications to show that there should not be a question about this. Diet does matter in pain management. And we know that because we know it can reduce inflammatory mediators, deficiency and insufficiency, introducing anti-inflammatory components of the diet, as well as contributing to secondary benefit, including improving mood, sleep, function, and even possibly medication requirement, which, as we know in our current surroundings of issues with opioids, can be a significant area of interest. I put this up just as a reminder, somewhat humorous, to say you got to start somewhere. And I think many of our populations work with, all the P's and Q's and R's are not going to be possible on day one, but it might be just reducing the soda. It might be reducing the chips. It might be not eating their meal in the car as they're zooming to work, but really taking a step back and really taking a look at it and starting with some simple ways to then begin increasing in fruits and vegetables, bringing in anti-inflammatory foods that are going to increase their magnesium, increase their pre and probiotics, increase their healthy fats, and try to begin to create a synergy which these components have. Again, they're not happening in isolation. In many cases, one food with one component will have benefit in a number of other areas, and that combined with kind of pushing aspects of the standard American diet to the side, incorporating activity, physical activity, incorporating mindfulness, both with our diet and our life in general, I think can have the most significant impact. I will, just a few other key pearls that I found is starting with some patients that have other symptoms that we know will likely benefit is a good way to start. So if somebody has IBS and they may have issues with obesity and shoulder pain, and you may put them on a specific anti-inflammatory diet or something for their IBS, when those symptoms begin to improve, they will have much better compliance. So starting somebody day one with severe neuropathy on the anti-inflammatory diet may be a while before you're going to see a massive reduction in pain. But when you look at that person, they often have other issues. It might be fatigue, it might be headaches, it might be issues with dysbiosis. So having them track those as we're going towards pain reduction, pain relief is key for compliance. Always good to work with nutritional experts. My dietitian I work with, Kathy Garvey, has been amazing. We also have a cooking class. So it's not just about telling them how important this is, but how can this person incorporate it, and watch the pendulum of foods. Don't try to make certain foods evil. I think in many cases folks are always looking for that silver bullet, and the key component, key message here is a slow shift. So a little bit less of this, a little bit more of that, and over time, kind of helping that slow transition as opposed to this is all good now and that's all bad. So you don't want to vilify foods, but just help them make healthy choices. And again, the big picture is reducing excessive calories and eating mindfully as a starting point. That can go a long way in helping many of our patients who not only have pain, but the overriding stress and maybe sleep issues and functional changes which go along with that, and using mindful eating as an approach which can help not just their pain, but their overall outlook. Advocacy, as I mentioned early on, we need to look at how do we get the message out. This is an editorial that my colleague and I did from Duke, and when you see a writing that talks about pain management and you don't see diet mentioned anywhere in that, that's a problem. That's that sort of question mark. Should we include it? Should we not? And if they don't, we need to call folks on it and say nutrition should be at the table for every aspect of this discussion. And as far as final thank yous of folks in my center, both with research and dietary services, Dr. Cotter with the VA who helped put this together, more information, and as well as the integrative pain management folks, more information about that conference as well as additional article on that component that we presented. Thank you so much for your attention. I hope this has been helpful.
Thank you, Dr. Bonakdar, for that wonderful presentation, and thank you for taking a few questions. Can you tell us why is diet not treated the same way in pain as it is in the management of other conditions?
Well, I think part of that has to do with pain not being seen as a chronic condition in and of itself, which it definitely is. It meets the criteria for that. But in many cases, we see it as sort of a sequelae of diabetes or the cardiovascular disease or whatever it might be. And so it sort of gets treated as a side issue. And in this case, doesn't get the education in medical school or the training arenas, so that at the point where someone's seeing a patient, nutrition is not seen as something to use for their pain, but if they say I have diabetes, obviously we're going to talk about nutrition. If they have issues with cholesterol, inflammation, metabolic syndrome, looking at it from a cardiovascular standpoint, we're going to use it. Even in mental health, those organizations have now said we need to talk nutrition. So I think it just takes more clinicians to sort of step forward and say, absolutely, it's not a question mark anymore. We need to put out guidelines. We need to put out recommendations, put out handouts. So I think resources, education, and advocacy and confidence are some of the things that, as they increase, I think we'll see more of a parallel between pain and other conditions.
Excellent. Thank you. And with all that is going on with the pain and opioid epidemic, where does diet fit in?
Well, I think I see it as a very hopeful, beneficial adjunct to how we approach that epidemic. There's no easy answers. We've seen many states struggle with that as patients have restrictions on the pain medications they've been used to for a long time, and there's obviously benefits to that, especially when it's being overused. But in some patients, as those medications are being restricted, there's not always easy access to a number of other interventions which we know can help. So although there are recommendations for non-pharmacological approaches such as acupuncture, biofeedback, mindfulness, etc., there's not always there's not always a discussion of how nutrition can be one of those non-pharmacological approaches. But I see certain centers that deal with these populations beginning to use nutrition because they see that same patient who's been on opioids for their chronic pain is also likely having is carrying extra weight, carrying extra inflammation. They might have fatigue based on other factors. So nutrition can kind of hit multiple aspects of that. And I think as more programs incorporate it and publish it as part of their non-pharmacological package to help these patients, I think we're going to have more and more centers use it as well. And we've seen that in our practice.
And lastly, what are the key ways to make implementation of nutritional pain management a reality?
Well, I think some of the key steps in the last few slides are ways to make it happen. But from just a clinician standpoint, I don't think a lot of patients have had that discussion with many providers. So they go in with their knee pain and they're used to having discussion of physical therapy and anti-inflammatories, and just beginning to transition that discussion to say there's other ways to get anti-inflammatory benefit to that knee. And have you ever thought about using nutrition, especially in populations where we might have assessed that nutrition may be poor or suboptimal, and talking about magnesium, vitamin D, Mediterranean diet, especially in conjunction with other practices, can have very strong anti-inflammatory potential. And you'd be surprised that our patients, many patients are looking for new areas of hope, because they, in many cases, have kind of been stockpiled on various pharmacotherapy, treatments, interventions, and if they don't have the final benefit that they're looking for, they're always looking for other options. And I think we as clinicians can be the most evidence-based folks that can help guide them to make good choices. And again, not go on that pendulum of the magic diet for whatever they might be having issues with, but really begin to use a slow shift to see if it does help their knee pain, as an example. So I think that's most impactful as a clinician.
Excellent. Thank you, Dr. Bonakdar. This has been an enlightening evening. Good night and best of health to you all.